quite a number of participants, a long list, and I did take a glance at the list earlier this morning, and you have representation from the various stakeholder groups. And today, what we'd like to present to you in this joint initiative is the EU perspective, the member state perspective, and the stakeholder perspective. So we have a number of speakers, quite a packed session, a 2-hour session this morning, and we will have a question and answer session, and we'll see how that goes during the event, or maybe halfway through, or maybe at the end. But just a few housekeeping rules. If you wish to ask a question, the easiest way is to use the raise the hand function, and then our team will actually allow you to speak so that you can put your question, or a written question, which will be put as well. So hopefully we have the MEPs who've joined. Is that so, or are we still waiting? Just to ask.
We have already some MEPs on the line.
We do, fantastic. So without any more ado, what I'd like to do is initially welcome and thank the MEPs of the Equitable Access to Healthcare group, and they're going to say a few opening words before we actually get into the various topics today. So first of all, I hope I've pronounced their names correctly. We have Sarah Cerdes, MEP. We have Katarzyna Koneczna, MEP, who will speak later, but not at the moment. We have Andrzej Kovacev, and we have Tomislav Sokol. So would you like to say a few words in order? So Sarah, Andrzej, and Tomislav. First of all, Sarah, the floor is yours.
Thank you very much, and I would like to thank the Patient Access Partnership to organize this very important event. As you're aware, I'm one of the co-chairs of the interest group on equitable access to healthcare, and it is very important to discuss with the different stakeholders how we can improve the accessibility of healthcare. Before any actions are taken, and me coming from the medical field, but specifically also from sciences and being a researcher, for us to do any actions, we need to identify the gaps that are there, and we need to ask where, to who, and why they happen. And for that, we need different indicators to better evaluate healthcare coverage and accessibility across the whole EU. I'm sorry about the notifications. This will allow us to have these indicators, will allow us to have more data and hence more information to discuss and establish a plan with well-defined targets to tackle the unmet needs of European citizens and European patients. So because we need to ensure accessibility to healthcare as one of the principles of the European Pillar of Social Rights, and given that this pandemic unveiled many things, but one of the main take-home messages is how important is health to the society and the importance of resilient healthcare systems and how these services shall be accessible, fair, and being given on time to everyone. We have now, and I'm almost finishing with these remarks, we have now that in EU, we have the EU for Health program. So it's the new health program, and it aims to achieve universal healthcare coverage, and the EU Health Union will be one of the mechanisms together with the others that will contribute to achieve these goals. So our success to improve accessibility across the EU is dependent on our capacity to work, in our capacity to discuss, but also, and most importantly, in our capacity to act together in providing the essential care to all according to the needs of each individual. So I finish now my remarks here, and I wish everyone a very productive event.
Thank you very much, Sarah. I now move to Andrei, if you'd like to say a few words.
Thank you very much, and welcome to all healthcare stakeholders, to my colleagues, to the experts, to the guests. I'm very pleased that we in the interest group of Equitable Access in cooperation with PACT are organizing this event today. The last 1.5 years was only focused on the health crisis, on how to overcome the socioeconomic impacts of the crisis, and what is the added value of the European Union in the health sector. This is now in the core of all debates. This is why I'm very pleased that you today are so many, and we can hear a lot of interest points. In the last mandate, I would like to remind you that our interest group created this suggested this pilot project for more efficient, effective and reliable measurement of access to healthcare. So the Commission now is working to expand the work conducted in the context of that framework. And just a few days ago, the expert group on health system performance assessment published a report on measuring access to healthcare. And I'm pleased that the report will be put in the broader context of the action plan to the European Pillar of Social Rights, published on the 4th of April, no, 4th of March. We all are aware about the profound impact of the current pandemic on our daily life. And as the EU works to overcome the consequences of the COVID-19 pandemic, implementing the European Pillar of Social Rights is a key to ensuring the society in fair and inclusive manner. I would like to wish you a lot of fruitful discussion, and as usual, our interest group in the European Parliament is on your disposal of all health stakeholders, what we can do better and more. And I think the whole European society and the whole world now realize that without healthy people, there is no economic growth, there is no progress, and we need to be much more efficient and much more investing in this field. Thank you very much, and all the best from my side.
Thank you so much, Andrei. And now Tomislav, and after Tomislav, Susanna, the chairperson of the Patient Access Partnership, will open with a few words. Thank you.
Thank you very much. Thank you for being with us today and taking part in this webinar, in this event today. I think definitely what and I'm glad for that this is the case, is the fact that healthcare has really become one of the priorities of the European Union, which was not traditionally the case. I always like to say that the problem with European health policy up until this point was that there wasn't one. This is changing, I think, for two main reasons. One reason is obviously the COVID-19 pandemic, so that is the main topic of European Union today. But also the fact is that in this European Parliament mandate and the term in office, also the idea of beating cancer, having beaten cancer as one of the European priorities, has also taken shape. And now you know that also in main part due to the activities of the European Parliament, now we have the special committee on beating cancer that I'm the member of, but we also have the European Commission's Europe's Beating Cancer Plan. So we have these two big initiatives in the area of healthcare, which are kind of, I think, most important issues that European Union is dealing with in terms of healthcare today. What is important is that this whole situation with these two topics, mainly because of the COVID-19 pandemic, has created an atmosphere where we in the European institutions are starting to discuss many different aspects, many different problems that healthcare systems in Europe are facing today. And what is important that what we discuss in the European institutions is our area that we discuss things which are concrete, so that we do not just speak in principles about what we can do, but that we turn these principles into a reality. And this is the topic for today, obviously. I'm always glad to have this kind of a more concrete approach, to speak about concrete measures that we need to undertake instead of more general things. We ought to do this and what we ought to do that. So that is one important thing, so that we are as concrete as possible. But also what is very important, that we discuss those topics where European Union can provide an added value, because still obviously healthcare is primarily a national competence, but there are areas where problems exist which member states cannot resolve by themselves. And one of these most important problems is the area of equitable access to healthcare. Because we know that differences in different member states of the European Union in terms of access to healthcare, in terms of standards which are provided, in terms of treatments which are available for patients, are so different. And while this exists, we cannot speak of one European Union, because currently, unfortunately, we have really citizens of first and second class in the European Union, which is completely unacceptable. So what I learned in the last several months is that there are 30 or 40% bigger chances of dying from cancer if you live in member state A than if you live in member state B. So while we have this kind of a situation, we cannot speak about European solidarity, about European Union, about European principles, values, etc. So this is one area where EU can do a lot. We have the cohesion policy funds, we have the EU for Health program, which is 12 times bigger than the previous health program. So we have all of these instruments. We have regulatory instruments as well to harmonize certain standards, which we can use on EU level to really make a difference and to turn equitable healthcare into a reality. So I think that we can do that. I think we now have the good political will and atmosphere on the European level to do this. And now it is time to speak of this concrete solutions on how best to do this. So what is the best way to allocate resources? Which are priorities which should be, what are the priorities that we should focus on? And I think that these kinds of events are good to really initiate discussions about all of this, because obviously we in the European Parliament, we can provide the policy framework, but we have to learn from experts about what concrete measures need to be undertaken. And we have to listen to the experts, we have to listen to the academic community and the people from practice as well. And I think that if we do that, if we have this political will to do something, if we take the positions of all the relevant stakeholders into account, that this is the only way that we can achieve our aims. And one of the most important aims that EU should be focusing on is more equitable access to healthcare. So Europe of first and second class citizens is completely unacceptable, and this is something that we really have to work on to stop, to resolve the situation as it is now, which is not very good at the moment. So thank you very much again for taking part in this, and I look forward to the discussion.
Thank you very much. And now, Susanna, if you'd like to say a few words.
It's my pleasure. Good morning from me too. I'm really pleased, in addition to the MEPs of the group, to welcome all of you at today's webinar. As the chairperson of the Patient Access Partnership, which indeed is a multi-stakeholder platform advocating for equitable access to healthcare across the EU, I'm really pleased to see today so many different stakeholders interested not only to learn, but to engage on what can be done to support sustainable solutions and approaches to improve healthcare for patients. Looking back in time, one can say that we have collectively made very significant progress. First, from defining health inequalities to recognizing the need for better access, from working in silos to joining forces in a constructive collaboration. Thank you really for being the engine of this change. Clearly, like our distinguished MEPs highlighted, a lot more needs to be done. This pandemic, in fact, exacerbated the pre-existing systemic healthcare problems and really challenged equitable access to healthcare, which was not equitable in the first place. But at PACT, we are really delighted to see the initiatives arising at the European level and honored to provide a policy platform for critical discussion and awareness. Against this background, today's meeting aims to generate a productive discussion on the new, more tangible solutions for making European health systems adaptive and receptive to the urgent patient needs. To me, today's meeting is extremely important also for another reason. The MEP interest group on equitable access to healthcare that was first established in 2014 with the support of PACT is now serving a second mandate with remarkable policymakers on board. Dear co-chairs, your continuous commitment only comes to remind us that there is a long road ahead until patients across the EU enjoy equitable access to healthcare. Today's meeting is designed to help show the path. PACT really thanks you for your dedication and is privileged to have a chance to support such competent and dedicated individuals, and to do that with our multi-stakeholder steering group and wider partnership. So I'm pleased to give now the floor to our distinguished speakers and encourage, like Lynne did in the beginning, all participants to actively engage in the discussions to follow. Lynne.
Yes, thank you so much, Susanna. And indeed, we are very much a multi-stakeholder group, as we've seen already from the list of participants, as I said. So we have three focus points today on the title, which hopefully by the end of this morning, we'll have a clearer picture of some of the outcomes that we can expect. So we have the EU perspective, which we start with, then the member state perspective and the stakeholder perspective. So without any more ado, I will ask Mrs. Katarzyna Ptak-Bufkens, who's policy officer at DG SANTE, to speak about the key EU instruments to make health systems more equitable and resilient. And she'll be followed by Dr. Ewout van Ginneken, a bit easier for me since I believe he's here in Holland, the hub coordinator for the European Observatory on Health Systems and Policies. So, Katarzyna, the floor is yours. Thank you.
Hello, good morning. Thank you very much for the invitation to this webinar. I would like to share some slides with you, but I had connection issues. I hope it will work. Let's see. Yeah, it should work. If you don't see any slides, please let me know. Can you see them?
Yes, we do.
Okay,
Yes.
perfect.
Yes.
It's a great pleasure to be here, and it's a great opportunity also for us, for the Commission, to share with the stakeholders the new product. We managed to publish a new report last week, which is the fruit of the whole year work with our experts on healthcare systems performance assessment. I would like to start by showing you a slide which may seem complicated. The problem is that I cannot. Okay, it works. What is the background of this work? Why do we invest? Did we invest so much time in improving the ways we capture problems in access to healthcare? As you can see, the comparable data which is available across the EU gives rather a confusing picture of challenges in access to healthcare. When, for example, you look at the population coverage, you could believe that we are fine in many member states, there shouldn't be issues. But when you juxtapose other indicators like catastrophic health spending or unmet medical needs, you see that there are some outliers, in those countries which seem to be fine when it comes to the population coverage. That's why we had some reflection a year ago to try to drive the future discussion, try to find better metrics to understand better what happens really on the ground, what challenges people face while accessing healthcare systems. Of course, the COVID pandemic, as it was mentioned by the distinguished MEPs and by Susanna, it changed the dynamic completely, and it only stressed that actually we need to get a better view of what problems people face in accessing healthcare. As I showed, the indicators which we have don't already obscure actually the more systemic problems, more structural issues of healthcare systems. And on top of it, it's difficult to understand in the dynamic of the pandemic what other challenges add on to the systemic issues. And we fully agree with what was said by the distinguished MEPs that we need to put more focus into the equity issues. That's why our ambition of the whole year work was actually to look what kind of metrics, what kind of indicators could help policymakers understand better what they should do to improve the provision of healthcare services. So to make sure that what we provide as healthcare services corresponds to the needs of people, and that there are some efforts which would actually allow to make a quicker progress to address the inequalities in access to healthcare. And as I said, I'm very pleased today to present you very briefly the recent product, which is the report of the expert group. And this work has a very important policy framework, because the Commission has also published the action plan for the implementation of the social pillar of the pillar of social rights in March. And one of the 20 principles is, of course, the principle of on access to healthcare. And one of the commitments is indeed to ensure that we have better measurement tools to provide for more targeted policy solutions to problems we see. And of course, there will be some follow-up of this work, which was developed with the experts. I will say a few words about it later. So the ambition of the report was indeed to, first of all, improve the patient perspective and how we capture problems in access to healthcare. But also to think, to break the silos in approaching accessibility issues. And to do it, it really requires try to mitigate through a policy mix the consequences of accumulated social, economic, and health disadvantage. And so the set of tools we proposed, we show in the report, indeed have this more global perspective, encompassing perspective, taking into account also other policies which play a role in reducing health inequalities. And we hope, yes, that this work will indeed give an impetus to more targeted policies and measures. The report basically presents three types of tools. One of them is the redistributive impact of health benefits, and I will say a few words about it. The other one is patient Vignette, and Ewout will develop on that. The report also provides a variety of tools which fit more the national context. And when it comes to the redistributive impact of in-kind health benefits, it might sound a bit complicated. So just to explain you very briefly, what I should say is that transfer from non-cash benefits and the associated tax and social security contributions have a very substantial effect on the distribution of the economic welfare, and this is how they impact on the poverty. And unfortunately, this is not being measured systematically. We find very few examples of member states who tried to do it, who tried to develop a certain methodology to show this redistributive impact, but this is not being done in a systematic way. We believe that this is something to be developed at European level, because we perfectly measure the impact of monetary benefits, monetary social benefits, but we don't do it for in-kind benefits, while these in-kind benefits represent over 30% of total social benefits. That's why
I'm sorry, you have 2 more minutes, so we're running a little over time, if you don't mind, sorry.
Yeah, so this tool would actually help us to understand better what role the health benefits play in the reduction of poverty, and that links perfectly to the headline target of the action plan of the European Pillar of Social Rights. It is also important to better understand what is the impact of the way we finance healthcare systems on redistribution of welfare. So this tool would also be actually be a good attempt to understand it better at European level. And the report provides a wealth of knowledge on the tools which fit better the national context. We understood through the survey we did with our experts that there are still some important dimensions which are not well measured, like patient experience, healthcare workforce, completeness of healthcare coverage. There is even less transparency on issues related to coordination or continuity of care. And the report provides some good examples of tools which are used already by some member states. So it's a good source of reference for those member states who might be interested in putting into work some of the tools. Yes, so just to show you that, yes, there are some good examples, some good case studies or more comprehensive approaches of measuring certain things. And the important thing I want to stress is that the report also shows how important the metric is in terms of policy impacts. And there are good examples of how member states use their national tools to make a policy impact. But yeah, if you are interested, you can have a thorough look in the report. So yes, definitely there is a big added value of having better indicators. First of all, we should think of patients, how to understand better their needs. We should address inequalities, and the report provides some ideas about it. And I show you the links to the report, and you are very welcome to comment, to contact me if you have any questions, any comments on this work. Thank you very much.
Yes, thank you so much. I'm sorry, but obviously this is a massive topic. I did look at the report yesterday, all 83 pages of it, but I'm sure with those links you can be redirected there. So Dr. Ewout van Ginneken, he's the hub coordinator of the European Observatory on Health Systems and Policies. If you'd like to take the floor, thank you.
Thank you. Let me just... I'm trying to open my slides, but it doesn't seem to work. Maybe Liana, you can give the backup. Because somehow it's not.
Just give me a second, and I will put them on.
Yeah, so I will be presenting the pilot we've done on vignettes and using vignettes in measuring access studies. I think there it comes online. Perfect. And I can, do I have controls?
I think you can request it.
Yeah, perfect. So why did we do this? Well, you seem to be very well aware of the metrics that are available and also some of the problems. Just really in short, there is a focus on out-of-pocket payments and financial protection indicators, but also unmet need data, which is very helpful and can teach us a lot. But for example, if you see that somebody has an unmet need because of cost, you want to know, is it because he doesn't have insurance? Does the person not have the benefits in his insurance package? Or is it because of high cost sharing? It's also, of course, valuable to hear that somebody has a problem due to geographic reasons. But then you want to know, is it for everybody or just certain care types, or is it in particular regions? So there are many questions left unanswered. What are the underlying causes? Can we link it to individual characteristics which would enable us to make better policy? Okay, click like this. Yep. And then we have the COVID-19 pandemic, obviously adding a whole new level of uncertainty. This is just from the Eurofind survey. We will have to see how this is going to affect all the other indicators. The question here is, since the pandemic began, have you needed a medical examination or treatment that you've not received? And you see that now 20% on average is saying we have. And, if you consider that it's only 3% in the EU Silk survey, of course, these two cannot be directly compared. It just shows that we really need to know much more about who is experiencing this access problem. So what was the goal of our pilot? It was actually a proof of concept to explore whether a vignette approach, which I will talk about later, can add to existing indicators and help differentiate between population coverage and realized access to care. So our work consisted of a survey we did in 2019, that you can also, is actually published, show that later, which identified a range of vulnerable groups facing access hurdles. It was also a rapid response request by SANTE. And the pilot study on the vignettes, which we did last year, where we had 3 case studies, 3 different vignettes for 12 countries: Bulgaria, Estonia, France, Germany, Italy, Lithuania, Netherlands, Poland, Portugal, Slovakia, Sweden, and the UK. So what is the vignette methodology? A vignette is basically a small description of a person or situation designed to simulate key features of a real-world scenario. Usually, a vignette is presented to relevant professionals to see what their hypothetical response or behavior would be. And they have been used in medical literature in many different forms and shapes to see how persons are treated, but also depending on their insurance coverage, if they are treated differently. They're even used also to compare costs between hospitals. So we had to select vignettes, particular types of care that we wanted to look at. And, oh, no, this doesn't work. I had actually introduced here a small animation, but okay, it doesn't work, doesn't matter. So these are all the coverage gaps that we found in our survey that is also published in Health Policy. And we selected 4 areas, of which 3 were published last year, and the 4th one we're working on. Namely dental care, we have stroke care, and also depression. So what we did was we drafted a brief description of a patient's age, medical complaint, and health history. Then and this is new, we looked at the recommended patient pathway based on international clinical practice guidelines and standard and wrote that also up. Then we made a table to incorporate the vignette into a framework for determining coverage and access. And we asked questions, how specific, whether the respondent could think of particular patient characteristics or any other factors important for the treatment of this particular vignette. And we asked, does this practice that we have based on international recommendations differ from how a person is actually treated in your country. So this is the example of stroke. I will only show stroke and depression. I'm not going to talk about this here in depth because there is no time for that now, but you can see that we basically broken down the treatment plan into specific services: ambulance, imaging, thrombolysis, thrombectomy, etc. And we did the same for depression, which is also a very interesting case study going through different types of care in depression care. And then we asked experts to basically fill out this table, which asks for each service whether it is covered by the statutory system, does cost sharing apply, is there financial protection, is there a lack of physical availability of the service, do patients face problems in obtaining the necessary care, or is there a problem with the attitude of the provider? And also this question, can you think of any other factors that could affect this access? So here we summarize the results for stroke vignette. And again, here I will not go into detail about this, but what you can see is basically green means full availability and red is not available at all. So for example, for stroke, you can see that there's a big problem with rehabilitation. In some countries, it's not available at all, which is pointing to serious deficiencies in the quality of the offered care. And here are the results for chronic depression. Again, I will not go into detail, but what you can see here is that there are very different hurdles faced by basically in every country according to this standardized treatment plan. So to conclude, we can say that the vignette approach can identify gaps in coverage and access to recommended care, as well as differences in treatment, which are for some much larger than you would expect perhaps. The pilot has revealed important gaps in coverage for certain areas of care provision that would have stayed under the radar when only looking at available services, if you only look at the benefit basket, even where formal coverage exists. And interestingly, if you compare with outcome indicators where available, for example, we have the 30-day mortality after stroke available, it can help explain the role of access in very bad health outcomes. I mean, often we're quick to assume, oh, the quality of the care that is provided is bad, but maybe there's an access problem here. And a vignette can make that really visible. And by doing so, I think it can help making a more detailed diagnosis that can be addressed by targeted policies. And in the report, which you can read here in full, we do some recommendations of how this could be scaled up and even be, further refined, and hopefully to make it more useful, even more useful for policymakers. Thank you.
Thank you so much. I'm sure there are going to be some questions, and remember, if you want to ask a question, then you can use the raise the hand and we'll monitor those questions. So that's from the EU perspective, and now we move to the member state perspective, very topical at the moment. We have speaker Dr. João Miguel Lança, who's the health attaché and permanent representation of Portugal to the European Union, obviously with Portugal as having the presidency right now. Very interesting to hear what he has to say. So the floor is yours. Thank you.
Thank you very much, Marilyn. Good morning to all. I believe you are listening me good. So good morning to all, and thanks for the organizing to the interest group to organizing this event, and also to invite us presidency. And I believe it's also a good opportunity to change views on such an important topics. Even, for instance, and thank you all for the interventions for our previous colleagues. I will take more in my intervention our goals and priorities. It will be our main purpose, and I will address at the end our perspective on the issue of the social pillar, European social pillar rights. So at the beginning and the starting of our presidency, it was clear for us that in the forefront of the European Union agenda during the first semester of 2021, it will be the COVID. That was at the beginning of our president, that was clear. And how does that impact in our president? First, of course, at the economical level, the impact was important to finish the negotiations of the multi-annual framework and also the next generation, and that was achieved. Now it's under preparation, the recovery and resilience plans. On the second impact, that social response to the crisis, that important to take in consideration the strengthening of the European social pillar, even more urgent, and I will tell at the end. And third, on the health policy response to the pandemic, the aim for our presidency is to work hard to ensure a good coordination among member states. Work closely also with the European Commission and other institutions. That was clear, and that was also reflected in the slide that you are seeing now. More concrete, as I mentioned before, today I will start with a brief presentation of the main priorities in the health area for these 6 months of our presidency, and followed by a quick look of the measures that could be implemented to respond to the challenges addressed by the demanding situation that we are facing. Portugal, of course, at the beginning intended to continue to carry out the important work done by our German colleagues, of course, and make good use of the Council decision-making abilities to allow our Slovenian colleagues to continue our work and achieve the Health Trio program. In fact, the Portuguese presidency in the field of health focused its attention on 4 major priorities that you can look at the slide on the screen. That 4 priorities are, and I will address it shortly, reinforcing the public health cooperation, building a European Health Union, of course. Building a European Health Union allowed to reinforce the European Union resilience for cross-border health threats. And on that, there are, of course, three legislative proposals that are on the table, and the regulation on cross-border serious threats to health, the regulation reinforced role for the European medicine agencies, and the regulation 2 amending the European Center for Diseases Prevention and Control. The European response to future health crises will be greatly improved of the building European Health Union legislative package as proposed by the Commission, and we welcome that initiatives and promote during this semester the negotiations in order to achieve as much as and to advance as much as possible. On the second priority that we consider for our presidency was supporting the sustainable, equitable and universal access to medicines and medical devices. And on that, we will pretend to have a council conclusions on supporting sustainable, equitable and universal access to medicines and medical devices, to work on the pharmaceutical strategy for Europe that was presented late November last year by the Commission, on the regulation on health technology assessments, where we are now still to enter negotiations with the European Parliament, and I believe we will start soon, and the implementation of regulation on medical devices. Regarding this topic of the access to medicines and medical devices, our presidency, our intention is to pursue a European agenda based on sustainable and universal access to medicines and medical devices. For the third topic, the promoting digital health, our intention is to work in increasing the digital skills of citizens and health professionals, improvement of health data infrastructures, and revisit the legal and regulatory framework to allow health data to be made available for multiple uses, and building a data sharing ecosystem to ensure long-term sustainability and address the existing barriers on the development of cross-border telehealth services. In this field of digital health, our presidency, the intention was driving its efforts towards expansion of the existing exchange of information between member states with a view to contribute to the creation of the European health data space. On the fourth priority, on the strengthening of the European role in the global health, our intention is to focus on the health gains on One Health approach responsive to the challenge of antimicrobial resistance and vector-borne diseases in the context of the climate change. Also taking in the negotiations the multiple context and the global architecture with a focus on WHO reforms and the Africa-European Union strategic partnerships, dealing also with, as it was already mentioned by in the previous intervention, on the European Beating Cancer Plan and the community approach with regards to the health promotion in mental health. Also on this area, we organized an high-level conference in Lisbon on last 25 of March to discuss the strengthening of the European role in global health. Our focus on, as I mentioned, on the global health is to focus in areas on the convergence with the aim to sustain a health gains, as I said, and our intention is to strive to respond to the challenge posed by antimicrobial resistance. It's one of the main areas. I would also highlight that we in the last work in the last council, informal ministers' council of health, we tabled a discussion on the European Cancer Plan in the last 16th of March. But of course, as I mentioned at the beginning, during this semester, we will have for sure the COVID, and we need to deal with it. And we deal it in the several political dimension and fora at Coreper level and on the integrated political crisis response, on more recently on also on the negotiation of the Green Digital Certificate, and also tabling the discussion on the response to COVID and several meetings of ministers of health that were already organized by the presidency, namely, for instance, on 13th of January, 1st of March, and 7th of April. Our goal, of course, on this is to also aims to reinforce the ability to respond to the public health crisis. And in that light, the focus, no doubt, is to be given to ensuring an efficient rollout of the vaccination plans across Europe. It's challenging, as you all know, but it's one of the main concerns also for us on this semester. I also like to, in the next slide, please, to highlight the few events that we will organize in Lisbon. For instance, on end of this month, we will organize an high-level conference on the access to medicines and medical devices. On 3 of May, we will organize European Cancer Research Summit and in a joint event with Ministers of Science and Technology. And on June, we will organize on the e-health 19 e-health network meeting and the e-health summit. So it will be important events to discuss and prepare the future on health in Europe. I will also now, and after this brief overview of our main priorities, add something on the European pillar of social rights, namely taking into consideration the principle 16, the healthcare. And as you know, it's mentioned that everyone has the right to timely access to affordable, preventive, and curative healthcare and good quality, of good quality. and how does it link with our presidency and our work in progress. In particular, in what regards to healthcare, the following points must be underlined. For instance, regarding the topic of access to medicines and medical devices, our presidency intends to continue to pursue a European agenda based on sustainable and universal access to medication, as I mentioned also before. And we will, during this semester, give priority to activities in relation to the availability of medicines and medical devices, to ensuring an equitable access to these essential products. Also to the production capacity of critical active substances and medical devices in the European Union to better preventing, mitigation and managing potential shortages. How do we try to manage this? We will prepare a proposal on the draft of Council conclusions on access to medicines and medical devices to present to the ministers, health ministers meeting EBSCOs on June, and we will prepare it after the and taking in consideration the discussions that we will have it on the high-level conference on the end of these months. We also pretend to continue building on the European pharmaceutical strategy and reinforce the role of the European agency in coordination with the network of national agencies and closely monitoring the work in progress for its implementation. Our goal for the European pharmaceutical strategy is to be developing close interaction dialogue so that concrete solutions which met the needs of member states and European citizens may be pointed out. We also continue to prioritize the implementation of the European Cancer Plan in a coordinated manner with member states and using, as what was already mentioned, the fora that were and the groups that were already created for it. And in the field of digital work, the digital health, we will continue to drive our efforts towards expansion of existing exchange of information and try to create conditions and inputs for the creation of a European health data space. We will focus and mainly in the events that is presented on the slide to development citizen digital skills, the promotion of better infrastructures, and the creation of a legal and regulatory framework which allows for improved provision of health data for certain purposes. We also would like today to give some examples of policies that we believe that could be adopted in order to facilitate access to healthcare, even during a pandemic, some of which have been implemented in Portugal. And a few examples that we would like to stress today, namely the strengthening the public health authorities in order to avoid the surge of new cases in this context of pandemic, managing health systems so that they prepared for peaks in pandemic context by estimating the necessary hospital surge capacity, adapting safety measures in other facilities, implementing telemedicines and e-health solutions, and strengthening patients by protecting the most vulnerable groups of patients. So this is all needed to be discussed, and I believe also the report that was presented last week, it's also a good moment to discuss these issues, taking in consideration the evaluations and the conclusions addressed on the report. Let me conclude my intervention reinforcing that the implementation of the European Pillar of Social Rights of the European Union as an instrument to reinforce the social dimension of the European Union is one of the top priorities of the Portuguese presidency of the European Union for this semester. And indeed, the European social dimension is one of the elements of Europe's economic recovery, which you want to be fair and inclusive and as a buffer for social impacts, economic and labor consequences of climate and digital transition, are the foundation of the rationale of this political priority of our presidency. So let me conclude saying that the Porto Social Summit scheduled for 7 and 8 May next May 17, the next 7 and 8 of May will be the high point of the Portuguese presidency of the Council and is aimed at setting the European agenda for the next decade and ensuring that we face the challenges of the present and of the future, leaving no one behind. Its aim will be to promote a debate of the strengthening of the European social model and how to achieve the 20 principles of the European Pillar of Social Rights. So, which includes, as I mentioned before, the principle of the healthcare. So this is our main points for today, and thank you very much for your attention, and thank you very much.
Thank you so much. An awful lot to take in, and many of those events. Indeed, it would be great to be able to fly off to Portugal and attend some of those events, but I'm afraid I think that's not feasible for the coming period. But please don't forget to ask your questions. We now move to the stakeholder perspective. We have 3 speakers here, and the actual title is "What is Needed to Turn a Vision of European Health Union into Practice?" And we have Mrs. Ingrid Stegeman, and her presentation will remind the audience about the inequalities in health not being due to the inequalities in access to healthcare. So that's quite a topic. And then we will move to Dr. Daniel Lopez Acuña, who will also talk about the inequitable access to health and related social services in Europe, and on the specific work and findings of the Joint Action on Health Equity in Europe initiative. And then we move to Simona Guallardo, who will indeed be speaking about the pandemic and health having become a top priority for European leaders. So first of all, Ingrid, if you can take the floor and guide us through your talk. Thank you.
Okay, thank you very much. I don't know if someone can pull up the presentation. That might be easier. Otherwise, I can try to pull it up.
Yes, give me a second.
Okay, let me take control. Okay. In the meantime, I can get started. Well, thank you very much for this opportunity. In this presentation, I'll indeed zoom back out a bit and maybe start by introducing EuroHealthNet. Oh, I'm not sure. Yeah, I can't. Let's see. Let's see if I can control the slides, but it's not letting me. So next slide, please.
Okay.
There. So EuroHealthNet is a European partnership for health, equity, and well-being, and our members are mainly all statutory bodies, so mainly institutes of public health, but also some regional bodies, local level authorities, and research institutes. And our focus is very much on well, I often say EuroHealthNet is not your healthcare net, it's EuroHealthNet. We try to keep people, we see what can be done to keep people out of the healthcare systems. So by focusing on prevention, promotion, and also very much looking at the issue of health inequalities as a cross-cutting theme throughout all of that. Next slide, please. Next slide, please. And because, as we all know, when disease presents itself, it's often just the iceberg that we're seeing, the tip of the iceberg, and that there are many underlying causes that are leading to that disease, whether it's the underlying housing, employment, social support conditions, things like that. And then beyond that, the structures, the economic and social structures that are leading to these differences. And the WHO Health Equity Status Report really reflects that, in that they did a decomposition analysis of the factors that are contributing to health inequalities in self-reported health. And they found that about 35% of these factors have to do with the financial insecurity and not being able to make ends meet. Almost 30% had to do with, for example, the quality of housing, and only 10% really had to do with the quality of access to quality of healthcare and access to healthcare. So what, well, in the pandemic, we really have seen this in terms of the inequalities in terms of people that exist, in terms of people suffering from and catching and dying from COVID, that we see huge inequalities there. And those are often due to those underlying conditions and the underlying factors that were affecting people, and that they still had to go to work or lived in poor housing conditions and couldn't self-isolate. So that's really brought that to bear. And it also really shows that the pillar of social rights isn't just of social rights, it could also be seen really as a pillar of health rights, so a pillar of health, and it's an incredibly important tool for health too. Next slide, please. What I also really wanted to underline is the importance of mental health in all of this and how interrelated these things are, physical, mental health, and health inequalities. And there's so much research out there showing how health inequalities really affects mental health and at a societal level. So often when we're talking about access to healthcare, we are forgetting about the mental health. There is an improvement in this and more attention for this, again, especially due to the COVID-19 pandemic that's and raised anxiety levels throughout, but throughout societies, and realizing how interlinked these issues all are. But still, we need to put much more of an emphasis also on mental health. And health inequalities really does affect all of our mental health. So all these social, emphasizing the pillar of social rights, reducing and taking those actions to reduce those inequities is also a very important measure to improve all of our mental health. So again, really focusing also on those social determinants of health as health tools. Next slide, please. So this obviously doesn't mean that, okay, let's disinvest in health and focus more on social determinants. Health systems, healthcare systems have an enormously important role to play in our societies. But we can, there is a lot of work that can be done in terms of restructuring where the emphasis lies within our health systems. And Professor Jan de Massenaar, who is chair of the European Commission expert panel on effective ways of investing in health, has often presents and talks about this model, the need to turn upside down the health pyramid so that there's much more of an emphasis on primary healthcare, community healthcare, and health promotion and prevention. I think together that only constitutes about 19% of health systems. Of that, promotion prevention only 3% of the cost of investments in health systems, and we really need to strengthen that in order to make health systems more sustainable and to reduce unnecessary costs in secondary and tertiary care, and that's unnecessary suffering, we can also say. And by focusing more on promotion and prevention, I also want to emphasize that it's not about more campaigns to get people to eat right, to move more. I think everybody knows by now what needs to be done, but of course we don't all have the same abilities and skills to be an agency to be able to put that into practice. So it's really, again, looking at the underlying
what's needed, what people need to be able to put that into practice. And I think Michael Marmot, whose name you saw there as one of the key figures in the key researchers in this field, recently said that that studies have been done in England that if the poorest segments of society would have to invest about 70% of their income in terms of in order to follow the British healthy eating guidelines, for example. So obviously it's not just a matter of telling people what to do, it's enabling them to do it too. Next slide, please. So we need a more holistic approach to health and also access to healthcare, and that means, as Katarzyna also mentioned, and we're happy to see that being emphasized more and more, ensuring stronger links between health and other sectors. It means more of a focus on proportional universalism. I just mentioned Michael Marmot. This is a term coined by him as the chair of the social determinants of health, and it's putting effort and resources in proportion to where it's most needed. It's easy to say, it's very, very hard to do, but so much more can be done in this area in terms of policy making and really looking at the impacts and whether it's progressive and or regressive. And we see so many policies still have much more of a regressive impact. They burden the people with fewer resources and less agency because of that, much more. It also means much more of a focus on participation. These are all buzzwords, but it is so important. And again, the report that Katarzyna mentioned does focus on this much more. We need to listen to people themselves and which barriers they're really facing in terms of accessing the conditions for good health. At the primary care, community care level, it's also developing more individualized care paths. That means maybe people don't need really the medical interventions, but they need more social interventions. We've all heard the reports on loneliness. Loneliness is many things are the new smoking, sitting, and whatever, but loneliness is definitely a very important cause of ill health, particularly amongst older people. So social prescribing is a very interesting new field that still requires research, but is an exciting area that is very much linked to that community, the new community health models that I was discussing. Well, value-based commissioning is just another important area, obviously, of how the health systems can make an impact in the global. It's such an important economic sector too. But all of this takes building new skills and capacities within the health system, so that they're really looking, improving how they can really take the actions needed also to improve access to health and not just healthcare. Next slide, please. In terms of data and measurement, we are very happy to see some good new sub-indicators within the social pillar of the social scoreboard, particularly, for example, sub-indicator on standardized preventable and treatable mortality. But obviously it would be so much better if these could also be disaggregated by income and employment status, so we can really see what's going on within and between countries across population groups. What would also be wonderful is to be able to see more data correlated, the health data correlated, particularly at municipality level, as with other things that are going on in terms of green space or energy use, to see really the patterns, where are the underlying causes of these inequalities. And more, as I mentioned, quantitative information to understand where people's real barriers lie. And there is this data revolution. There's a lot of potential in gathering more information from people to be able to diagnose problems. But of course, we also have the digital divide and digital exclusion, and the need to improve digital health literacy. And again, it's very easy to talk about and say, but really putting the resources, the universal proportionalist universal approach, how do we really address these issues so that we put the resources and help people to develop these, who most need these skills, develop them. That really needs a lot of attention and focus, rather than just that we pay lip service to these things to create health.
Could you wrap up?
So my last slide.
Yeah, thank you.
Last slide, please. I just wanted to mention, but Daniel will speak much more about this, that Your Health is part of the joint action on health inequalities, and it's taking this holistic approach to health inequalities, looking also at monitoring and improving access to health and social services. And again, Daniel will focus on it, but it's really action-based, and there'll be much more information out on what these actions are. So, so concrete measures that member states are taking that we can all learn from. Sorry, now my last slide. So just in summary, improving access to health in order to create more sustainable health systems requires a move above all beyond the overly biomedical focus, and also we also need to include a much more psychosocial focus. And Your Health is a big concern that the current plans at DG SANTE take this very biomedical focus with a lot of emphasis on preparedness for the next pandemic, but less on looking at the true causes of ill health amongst the populations. So act within and beyond health systems. We need to prioritize community health, primary health care, prevention and promotion much more, disaggregate and link data more, and address digital exclusion and improve digital health literacy. Thank you.
Lynne, we don't hear you.
Lynne, we could not hear you.
Yes, I had my Wi-Fi went. So I'd like to introduce you now, Dr. Daniel Lopez Acuña, who is the adjunct professor of the Andalusian School of Public Health. And indeed, you're going to talk further about the inequalities and about the joint action for health equity in Europe. Sorry, my Wi-Fi went down for a moment. It's back again.
No problem.
I hope it's better in Andalusia.
Yes, well, I'm currently at the north of Spain, but it's better, I would say, yes. Okay, good morning to everybody. I would like to thank the organizers, Patient Access Partnership, for the invitation, and I would like to project the slides, if you are kindly putting them in the screen. Perfect, thank you very much. And I will be indicating to you for passing to the next one. So I'm going to, the next slide, please, concentrate on discussion on the importance on inequitable access to health and related social services. Of course, the social and economic inequities at large are extremely important and determine huge inequities in health status, but also in access to health services. And in addition to that, the inequities in access to health and social services worsen even more the existing health and social inequities. So we should not underestimate the relevance of overcoming the inequities in access to services. In my presentation, I'm going to be making reference to the main conclusions so far of the work stream on inequitable access to health services of the Joint Action on Health Equity. I'm going to particularly extract from the policy framework for action and the country assessment that we have conducted in 13 countries. In addition to this, we are now implementing 17 actions aimed at reducing inequities in access in 13 countries, and we will be reporting on these at the end of the joint action in the month of November of this year. The next slide, please. Well, one of the streams of the joint action on health equity that was described by Ingrid a few minutes ago is the work package 8, which I'm coordinating, which is a work package that is aimed at contributing to the goal of leaving no one behind in terms of access to health services and related social services. And it's essentially doing it through the support to the formulation and implementation of regional, national, and local strategies, policies, and programs that reduce inequities in access to health and social services. And of course, this also puts attention, this joint action, in developing member states' capacity to advance policies that are going to effectively reduce the inequities. But I would like to say, we are trying to concentrate in very concrete action, tangible elements that can be then expanded or adapted. And one thing that I also would like to mention is that we need to go beyond metrics. Metrics are important, but it's just the first step. And we need to make progress in formulating actions in those areas that are amenable to intervention, where we can obtain results in the short run or in the medium term. Next slide, please. I'm going to first summarize some of the salient points that we have developed in the policy framework for action, titled Towards a Common Understanding on Inequitable Access to Health and Related Social Services in Europe. The next slide. It's important to mention that in the previous EU-funded joint action on health equity, there was the conclusion that it was important to apply the equity lens not only to social determinants and other upstream factors, but also to health systems aspects. And this implies essentially two things. On one hand, addressing systemic issues that are aimed at reducing the existing gradient of health inequalities, but also addressing the needs of specific groups that are generated or resulting from social exclusion processes and situations that can aggravate the already complex inequities that we have in health and the high vulnerability of these groups. The next one. It is also important to contemplate measures that increase and improve the universalism. This is a no way out. The situation of reducing inequities can be improved by targeted interventions, but we need to do it in combination with progress in universalism, in a way that the targeted interventions become a kind of affirmative action for mitigating the vulnerability of certain population groups with respect to the access to health services. But of course, our fundamental purpose is to identify key entry points that can reduce the barriers for access to preventive and curative care. And I would like to say the pandemic that we have just passed through highlights the importance not only of the personal individual health care, but also of the public health services and interventions that oftentimes we do not include in the spectrum and we neglect. The next, please. Part of the importance that has been highlighted of the work that has been highlighted in the policy framework for action is that formulating and implementing evidence-based recommendations for improving the access to services. It's critical for not leaving people behind, either because they are vulnerable groups or because there are some other access barriers that are more structural in nature that are hindering it. The next one. So the critical actions needed as identified in the policy framework for action have to do with addressing access inequities for those who do not benefit from services and identify the necessary actions for mitigating the bottlenecks. This, of course, requires also to concentrate on different vulnerable groups and different types of services with unequal access. Not all the services that supposedly are to be provided to the population have equal access, either geographically or because of functional elements of access that are, or financial barriers of access that are creating barriers that ought to be reduced in this regard. Part of the attempt of this joint action is to identify good examples of policies, strategies, programs to promote equal access to health services in those populations that are lagging in each country. The next one. The investigation of these access barriers then become critical. The measurement, but also the political economy of these access barriers and the factors that are amenable to intervention within them. In the reduction of inequities in access to health and related social services, there is a tension and sometimes even a contradiction between advancing targeted approach to vulnerable population groups. It's an attempt to undertake affirmative action in the delivery of services, but also the universalist approach that is encompassing general population measures that are aimed at producing structural interventions for the whole population. And I would like to insist that these second ones are more and more critical, as it has been shown in some of the results of our country assessments. There is complementarity between both. The next one, vulnerable groups are huge in our scenario in Europe, and this has to do with the fact that the social development processes have created lots of pockets of groups that are being left behind one way or the other in the access, in the effective access to health and related social services. And we have there a list of some of the groups that are experiencing some degree of inequity in the access to health services. The next one, please. Now, in terms of the possible measures to reduce inequities in access to health services, we have four types of measures. Those who are aimed at improving effective universality in the system, and a lot has to do with financing and common entitlements for all the population. The second, with measures aimed at improving the institutional capacity of the health system for translating the equity lens into policies, practices, and programs. The third is what we have been mentioning, tailoring the delivery of services to the needs of people in situations of high vulnerability. And the fourth has to do with measures that are aimed at developing and strengthening equity accountability mechanisms with the voice of all relevant stakeholders. The next one. So the main recommendations of what we have been doing so far in terms of the revision of evidence and also the assessment in countries are the following. A true equity approach should be a universalist one. This doesn't mean that one size fits all, but it is an approach that falls into the law that goes beyond the logic of repair policies and parallel health systems for the different groups in situations of vulnerability. We have to create systems that are truly universal. The two-tier systems should be avoided, and dedicated and targeted approaches within a framework of universal entitlements should be advanced. There has to be a basic floor of universalism and social protection for ensuring that equity is incorporated into the health system, correcting distortions generated by the social and economic fabric. The next one. There is also a reality of increased health needs and access barriers of persons living in isolated, marginalized, and vulnerable situations. We gave the list of some of these groups. There is consequently a challenge for identifying the most effective ways of targeting these population groups, involving them in the definition of their situation as much as possible. And it is important to note that there is a risk of oversimplification of the notion of vulnerability that should be avoided. And similarly, the risk of excessive segmentation of vulnerable groups that may lead to what we could call a balkanization of the health system response to inequities in access. The true equitable response has to do much more with building the increasingly universalist effective approaches to access to healthcare. The next one. So just to give the next one, a couple of considerations on what we have found in the country assessments conducted in 13 countries through the joint action, is that the majorities of countries declare universal coverage, but most countries report that there are co-payments for drugs, that there are some services that are not covered or only partially covered, like dental care, rehabilitation, mental health, that the majority of countries report that access to certain services are exempt of co-payment for certain vulnerable groups and for certain uninsured groups. The next one. A majority of countries report long waiting lists for accessing some services, differential access depending on socioeconomic status, and geographical disparities. The next one. In terms of the population in situation of vulnerability, two population groups stand out significantly in all countries: Roma populations and children, mainly those children of vulnerable families that are at the biggest risk of poverty and social exclusion. But also an important group is the group of older persons. There is an increasing number of older persons and those of chronic and mental disorders, morbidity, and of social needs, placing a big financial burden on the social and health services, and at the same time, not resolving the matter appropriately for this population group. Many countries have groups of population that are also left out, like undocumented migrants, asylum seekers, minorities, and those who do not have the entitlements of public insurance coverage. The next one.
Daniel,
Yes.
I have to ask you to wrap up if that's okay. Sorry.
Yes, I'm wrapping up.
Thank you.
Yes. So we have a contrast between declared policies and reality. Universal health coverage is the norm, is the discourse, is the speech. But less than 50% of the countries that we surveyed in this country assessment of 13 countries reported that there are policies specifically addressing the reduction of inequities, only 50%. And fewer reported action plans for implementing the policy. So while the majority of countries reported that no population is excluded in the national health policy, the reality shows that there are many unmet needs in all countries. So policies for the coordination of social and health services, housing and medical and nurse education do not seem to be universally available across Europe or European health systems. And a number of countries reported that they are entirely unavailable for the health system. Okay, just the next one, and I will finish there. Although there is virtually universal coverage in all Europe, most of the countries have co-payment systems for several services. And this is a barrier for vulnerable groups and for those of lowest socioeconomic status. Yes, some have established exceptions, but they are insufficient to deal with the vulnerability of the groups. The next one. Roma and children systematically appear in all countries as especially vulnerable, and the lack of suitable collaboration between social services, employment, and other sectors as well is a critical issue for advancing the agenda. I'm going to conclude here. Thank you very much for your attention. I'll be happy to answer questions in the question and answer section.
Thank you so much. In the interest of time, I'm going to move to Mrs. Simona Guagliardo, who's been very patient. I'm sorry we're running a little late, but I didn't want to interrupt too much of the various interventions. So it's over to you. And I know the COVID pandemic is uppermost in most of our minds, and I know that you'll be mentioning it in your talk. Thank you. The floor is yours.
Thank you, Lynne. I hope you can all hear me well, and it's a pleasure to be here with you. And I would like to thank the MEP Interest Group on Equitable Access to Healthcare for organizing this discussion, which has been extremely interesting to listen to. I will not have slides. I will share a few considerations on what is needed to turn a vision of a European Health Union into reality and why we have this need. Just let me introduce myself. My name is Simona Guagliardo, and I'm a policy analyst working at the European Policy Center, which is an independent, not-for-profit think tank. And we are dedicated to fostering European integration through analysis and debate. What we mainly do is we provide a platform for engaging stakeholders and partners and citizens into EU policy making and in the debate about the future of Europe. So what the work we develop at EPC under the Social Europe and Wellbeing Programme very much looks at the social dimension of the European project, and we try to find answers to the very familiar question, how can the EU support national policies in this field, and how can the EU add value to the national efforts in building strong, sustainable and resilient, resilient is the buzzword, resilient social protection systems, and in particular health systems. So here comes the need to answer to this question, what is needed to turn a vision of a strong European Health Union that promotes equitable access into reality, into practice. But before sharing some considerations on this question, I would like to say something about why do we need a strong European Health Union that promotes access to care. And when we try to answer to this question, the very first thing we think of is well, we need to react to the pandemic. We need to react to the current situation. And we know that the pandemic is an unprecedented global crisis that has shaken the foundation of our social and security systems. It poses a huge risk to people. We know that pandemic is inflicting massive costs on the European population and society. Of course, it is causing unspeakable human suffering, and it has appalling socio-economic consequences. It has been mentioned by the speakers before me, the pandemic is also aggravating existing social and health inequalities across and within EU countries. And we saw that it hits individuals from disadvantaged socioeconomic backgrounds, people living in the private areas, for example, ethnic minorities, for example, in a disproportional way. This is because, and these are findings from the OECD 2020 Health at a Glance Europe. This is because individuals from disadvantaged socioeconomic backgrounds, they face an accumulation of risk factors, as I think Ingrid already mentioned. This accumulation of risk factors place those people at a higher risk of being infected, of exposure, and of complications and death from COVID. Besides the risks to people, the pandemic also poses risks to health systems, of course. We have seen that the spread of COVID has exposed national health systems' unpreparedness to absorb and react to the shock. And of course, it has exposed pre-existing structural weaknesses. National health systems are subjected to an overwhelming rise in the demand for urgent care, and all health services are under severe strain. Of course, we see the impact on hospitals and intensive care units. This impact is particularly harsh, but we need to consider that as medical resources are diverted to treat COVID-19 patients, of course, the pandemic has an adverse effect on other patients. Non-COVID-19 patients, of course, face disruptions to their essential care. these disruptions often result in the delayed or missed diagnosis, hindered continuity of care, and sometimes foregone medical care. Particularly alarming, I've read some very interesting studies on the impact of COVID-19 on cancer patients, and the effects of this disruption are likely to cause an increase in cancer death. Besides people and health systems, the pandemic also poses risks to the workforce. And I would like to stress this point because the health workforce is the backbone of our health systems, and it requires particular attention. We have seen that health systems were not prepared to confront this pandemic, and the health workers found themselves at the forefront of this response, and they found themselves stretched thin in many European countries. The crisis made pre-existing concerns around shortages of doctors and nurses more visible and acute in many countries, of course with differences within countries. So these are some of the things we think about when we try to answer to the question, why do we need a strong European health union? So to react to the pandemic, but we should always keep in mind that the pandemic has only exacerbated what was already in the making. So existing health inequalities and structural weaknesses were already existing. So I've already mentioned the impact of the pandemic on the most vulnerable segments of society, but I think it's also important to stress that the pandemic has exposed health systems vulnerabilities insofar as primary care is concerned. We have seen that our primary care systems are weak, and we're not able to confront such a crisis. We have also seen problems in the uptake of digital solutions. Digital health literacy is low across Europe, but we have also seen low levels of integration of care between different care levels. And I've already mentioned the issue of the health workforce. The pandemic has exposed the uneven capacity of European health systems, health workforces, which is already often impacted by the high labor mobility of health professionals within the EU. And this high mobility has exposed differences in the capacity of European health systems to react. I don't want to go into many details, but I just want to mention some of the findings of a study we have conducted within EPC on the health workforce. So I want to mention that from the findings we have, EU27 employment in the healthcare sector has been increasing actually at a steady pace since 2008. But despite this growing trend at the EU27 level, there are stark national differences in terms of the availability of health professionals to meet the care needs of the population. And those differences, which were already in the making, they of course became even more apparent once the crisis, the pandemic hit Europe, with some national health systems suffering from severe staff shortages more than other countries. So in terms of studying the trends of the health workforce, I think it's also important to stress that there is an issue with the demographic structure of the health workforce. As I said, the capacity of national health systems to meet the care needs and to make sure that that care is actually accessible to the population depends largely on the availability of healthcare professionals. Overall, the EU health workforce is older than the general economy, with that of some EU countries older than others, and more worryingly, health workforce is aging much faster than the total workforce. So the age distribution of the workforce and the stark differences between countries raise serious concerns about future shortages of professionals in the sector. So as I already mentioned, the pandemic has only exacerbated concerns around staff shortages in health. Health systems across Europe are faced with several specific challenges. Being a pillar of social security systems, health systems must ensure affordable access to quality care for all. They need to meet the evolving needs of an aging population. They need to address the growing burden of chronic conditions, for example, and at the same time they have to embrace the mega transformations we are witnessing, for example, the digital transformation. On top of all of this, the pandemic has exposed the structural weaknesses and in many cases their unpreparedness. So we need to learn from what's happening, and considering some of the lessons learned from this crisis, health systems must become better prepared. So to come to the question, what is needed to turn a vision of a strong European health union into practice? A lot has been said by the speakers before me, and what I will say resonate a lot with their suggestions. So the Commission has put forward a number of initiatives, the first building blocks of this new vision for health in Europe. And a lot of work is being done on, for example, the measurement of accessibility and strengthening resilience. So I think that in order to build back better, another key word here, it is vital to act promptly and not to let this attention, this momentum dissipate. So both the EU and member states at all levels, they need to act fast. And I think that efforts must go in the direction of laying the foundations for resilient national health systems on the one hand, but on the other, we also need to rethink how we value health and how the COVID-19 recovery should look like. In terms of strengthening our health systems, we need to future-proof them. Since 2001, health expenditure has generally increased across Europe, with some countries, of course, spending more than others. But at the same time, if we look at investments, we see that investments in the health sector have decreased significantly over the last 2 decades. So the pandemic is a clear reminder that societies and economies are made more resilient and fairer through social investment that has been missing in recent years. So we need the social investment, of course, strengthens the citizens' ability to participate in work and social life, and it targets key areas like healthcare, like education and training, for example. And health systems in Europe are witnessing several concerning trends, as I mentioned, and we need more than ever to support our health systems and our health systems transformation in a way, because we need to boost effectiveness of health systems, we need to boost resilience against future health threats, and most importantly, I would say, we need to boost accessibility. So member states should pay particular attention, I think, to health systems reform within the context of the 2021 European semester cycle. This is a great opportunity which should not be missed, as the European semester has been intrinsically linked to the RRF, the Resilience and Recovery Fund. So I think it's more important than ever for investments to be targeted at strengthening our health systems. How to do that? many actions have already been mentioned, for example, strengthening primary care services. And I very much welcome what Ingrid was mentioning with the health pyramid proposed, inversing the health pyramid proposed by Professor de Masner. We need to strengthen our primary care services. We need to strengthen our community care services. We need to promote digital transition in health. We need to support our population aging in a healthy way. We need to strengthen the chronic disease management, and linking back to the considerations related to the workforce, we need to equip better our workforce and improve the working conditions of our health workforce.
Can you wrap up? Yeah, please.
Yeah, just one last point on the need to rethink how we value health. I was very happy to listen to Dr. Tedros a couple of weeks ago when he said that we need to see health and health systems not as a cost but as an investment that is at the foundation of productive and resilient economies. So we need to see health as a social goal. Yeah, so I think that it is high time that people's good health and well-being are put at the core of policymaking. So the European Union and member states need to realize that we need to pursue an economy of well-being. We need to acknowledge the link between people's well-being and health with social and economic prosperity. So we need to mold the COVID-19 recovery based on this understanding that well-being and health are crucial for social and economic prosperity. So I think I can stop here and happy to answer any questions.
Thank you so much, Simona. You've said an awful lot, and some of the words, if we say how health and social well-being, how important this is, and the value, and indeed it's a very packed session we have this morning. One question I have, could we perhaps ask the Commission, since we have the audience here, how can we actually provide feedback? And if we take the published report that you spoke about, any ideas on that? And then I want to get back to our MEPs and ask for their final comments on today's session. But first of all, what do you think? Anyone would like to take the floor on that one? Daniel, yes.
Yeah. Yes. Thank you very much. Well, let me take your question to highlight a point that I would like to put on the table, and maybe we all can debate about it. Yes, we have the recent report that has been issued by the expert group, especially related to measurement or to the metrics. We have the Euro Health Program, and we have the agenda for the social pillar or action plan on the pillar of social rights. But I am missing a much greater specificity and granularity at this point in all of these instruments, especially in the European Health Program, for taking into account the lessons that we have learned from the pandemic and addressing some of the issues that several of us mentioned, and certainly Simona highlighted at the end, of the need of strengthening the capacity of implementing the essential public health functions in all health systems in all European countries, which are not personal care or healthcare oriented, but public health interventions. The need for addressing more substantially the strengthening of primary health care, and the need for linking in much greater degree the health services and the social services. I think we need to bring it down to a much greater level of reality and granularity.
Okay, we have another question here, hand raised from Katarzyna. Could you perhaps? Yeah.
Yeah, just to maybe complement on what I said. Well, I fully agree that in my intervention, you probably missed the broader perspective of what we do. My unit deals with healthcare systems. Yes, the report which we publish is just a part of what we do. We look at the health system across the board. And for example, what we have right now on our agenda is the discussion, negotiation with member states recovery facility. And healthcare systems is of course one of the top priorities. Yes, this is very high on our agenda. So we are discussing with member states how to improve the capacities of health systems to deal to come out of the recovery stronger. Yes, to address the systemic issues. Another example of what is coming up from us is, for example, collection of good practices on strong primary health care. So this is forthcoming, one of the activities planned within the EU for health system. And we are also reflecting further because the program has just been adopted. We are reflecting further and developing other actions to support member states in building their effective capacities to deal with challenges. So
Yes. Thank you so much. It would be very useful, I think, after if we can have some of the links that have been mentioned today, and then everybody can take a very good look at what's been said. I'd like literally in 1 minute each, if our 4 MEPs could actually give their final views, and then we'll get back to Susanna, who'll close the meeting with a few remarks. So if I could go to Sarah, Katarzyna, Andrei, and Tomislav in that order, could you very briefly wrap up your comments? Sarah. Can we go to Sarah? Katarzyna? Oh, there's Sarah. There you are. No. Have we not got Sarah, Katarzyna, Andrei, and Tomislav?
Currently, I do not see her on the line. Maybe we can move forward.
Okay. Well, we can move on then, perhaps. Do we have anyone else? Tomislav, Andrei, Katarzyna, or have they all left?
I think our committed and dearest MEPs have moved to the next business this Monday morning. So
that's okay. So Susanna, I'm going to go over to you. I'm sorry, I can't see it myself, who's there and who's not there at the moment. So Susanna, would you like to give your closing remarks on a very stimulating session, I must admit? Thank you.
I guess I must.
Yes.
Okay. Thank you, first of all, Marilyn, who is, of course, representing here today the steering group of PACT, and thank you for moderating eloquently the discussion, and thank you all the speakers and the MEPs. So briefly today, in the beginning, we heard from our 3 MEPs who really laid down the issues regarding access and what they would like to achieve during this mandate for the interest group. They set the scene for our discussion. Then we heard from the Commission on what they are doing to support the member states in addressing some of those more systemic and structural issues on healthcare. And personally, I really welcome the especially the Vignette approach that was then presented, because in a way it highlights real life situations and barriers happening in the healthcare systems, also from the patient's perspective. For example, this issue about the area was depression, but the issue on not having a rehabilitation as a standard access issue. I know it's also from the disease areas that I represent, which is respiratory and allergy. That is a big issue. Then we heard how actually the barriers in the healthcare system, they are not necessarily that the quality care would not be available, but it is just not accessible, and nobody wants this kind of situation. Then we heard from the Portuguese presidency, and I would like to highlight there the council conclusions that will happen this summer related to access. I think this is an important piece of work, and I hope that this webinar also can have a contribution on the contents of it. Then we heard from the EuroHealthNet, who really put the emphasis on the inequalities and their impact on access, or the health inequalities before any access to healthcare is needed. And this is also very important for patients. Then we heard from Dr. Lopez on what the member states are doing together to help addressing inequalities, and especially how they are focusing on the vulnerable groups in the so-called YAHI action. Then, in fact, Simona from the European Policy Center actually summarized in a way around the whole discussion and contributions today. And she ended with the note on need to act now, promptly, in this and use this momentum, and to future-proof the health systems. So today was first this year in a series of the events of this interest group on access, who has always taken a very important report or a policy discussion item that is linked to access, and brought it into a wider discussion among stakeholders. And we have at the Patient Access Partnership, we have a new exciting project arising. We are actually going to highlight some good access solutions to healthcare that came up during the COVID-19 period. And we have a advisory group representing different stakeholders that is helping us in defining a criteria for such access solutions. So you will hear from us, and thank you again for the interest group and everybody taking this Monday morning with us. And I wish you have a good week on the good work that you are doing on access to patients in the EU. All from us, that's all from us now. I leave you. Thank you.
Thank you, everyone, and bye-bye from everyone at PACT here, and keep safe, keep well, and I hope the sun's shining for you today. Bye-bye.